And now I would like to move on to ocular oncology. We have two great speakers, and I would like to first introduce to you Professor Emine Kiliç, who's a graduate of the Erasmus University in Rotterdam with a PhD in molecular genetics on prognostic factors in uveal melanoma. After which he did a residency in ophthalmology and training in ocular oncology and vitreoretinal surgery, all at Erasmus Medical Center. For the past decade, she's the head of ocular oncology and the coordinator of ophthalmology education for medical students. Professor Kiliç has published more than 50 papers and is leading the analysis of uveal melanoma genetics, which we're going to hear about right now. Professor Kiliç, the stage is yours. We can see both you and
okay.
Wonderful.
Now we have the slides and the camera on. Okay, thank you very much for the introduction. And thank you very much for the invitation to speak to you on the molecular genetics of uveal melanoma. And I spoke with Shahar and he said, tell me about the new developments and the things you are doing, because that's most interesting. But I want to give a little update on what we did in the past and the current research we are doing. Let me see, get to the next. The disease-free survival for uveal melanoma hasn't changed in the past 25 years, and we still, approximately 50% of our patients still die due to metastatic disease. And yeah, we have improved the prognostication and things like that, but we haven't improved the survival. And how can we improve survival? Maybe because when we can prognosticate at an earlier phase, we might be able to change our screening protocols and then improve survival. For the genetic prognostic factors, which are the main, the genetic prognostic factors are the main we focus on in Europe, because in the United States they mainly focus on gene expression profiling to prognosticate the patients. And for the genetic markers, we know for many years now that there is a loss or gain of specific chromosomes, such as 1p loss, loss of a whole chromosome 3, gain of a 6p, loss of the long arm of 6 of the 6, it's a 6q arm, and gain of a whole chromosome 8. And if we look at the bottom part, we see what we did in the past, the FISH analysis, where we have 2 copies or 2 or 3 or 4 copies of chromosome 8. And only 1 copy of chromosome 3. And in the left bottom part, we see the Kaplan-Meier survival curve, and you see that when there is a monosomy of chromosome 3, that the patient has a worse survival. So we can, normally, when we look at the clinical features of the tumor, we have the AGCC staging in uveal melanoma, and that will say if you have a small uveal melanoma, the survival will be fairly good. If there's a medium size, it will be a little bit worse, and if you have a large tumor, then you have the worst survival. And then there was a study which incorporated the chromosomal gains and losses, like the gain of chromosome 8q and the loss of chromosome 3. And if they added that to the AGCC classification, they had a better model where they saw that the survival was influenced by these chromosomal changes. So when these chromosomal changes are very important, you want to classify them, and normally we have only small biopsies, or what we also have quite a few tumors. We wanted to have a platform, a sequencing platform, where we could identify mutations in cancer genes, because we know that there are a few mutations available at the moment. And we also want to see the gains and losses. So we had ion torrent sequencing platform in our pathology department, which had the coverage of the genes, and we could add new genes in the meantime. And we also could see gains and losses with the same technique. So that's something we use now standard in our pathology department for the diagnosis also for uveal melanoma. If we look at the current mutations, there are a few pre-malignant mutations already known, like the GNAQ, GNA11, this is LTR2, the PCBL4, and we also have mutations in genes which give rise to a malignant transformation of the tumor. And the most significant are the BAP1 and SF3B1. The SF2 does look a lot like the SF3B1 patients, but we don't know for sure whether these patients with an SRSF2 mutation in their tumor will metastasize eventually. And then we have the IFAX mutation, but the IFAX mutation doesn't give, it might give malignant transformation somewhere in the tumor, but it isn't associated with the worst survival. And on bottom part, we have a visualization of the right upper panel as the BAP1 negative staining for a tumor, which you see on the left is a SNP array that has a loss of the chromosome 3p arm. And the bottom one is actually a positive staining for a tumor with 2 copies of chromosome 3. So if you only look at the mutations in the tumors, we can distinguish high risk, low risk, and intermediate risk for metastatic disease. And this was already published in 2016, where we see if there is a BAP1 mutation, which corresponds to no expression of BAP1. We see the worst survival. The SF3B1 gives rise to late metastatic disease in the IFAX patients. Barely metastasize. And then we also have a group of patients which do not have any mutations and any known mutation at this moment. So what one of the former PhD students did is she looked at the group of patients we had tumors of, and she characterized those tumors for the chromosomal status, but also for the BAP1 and SF3B1 status. And she made this donut chart where we see that the half of the patients in our group has the BAP1 wild type, and the half of them is BAP1 mutated, and it corresponds nearly always with the BAP1 expression in the tissue. And then we see in the right lower panel, we see that the BAP1 mutated patients all die due to metastatic disease. So approximately 50% of our group has a monosomy of chromosome 3, but there is also a group of patients which have a disomy 3, but still can have mutations. So at that time, Harvard came up with the paper of the SF3B1 in uveal melanoma. And then there was another paper about the IFAX and SF3B1. And then we looked into our group and we saw that 10 to 24%, in our group is approximately 24%, had an SF3B1 mutation. And there's only the most common location is the arginine 625. And approximately 20% of the patients had the IFAX mutation. So we looked into that and we saw that the patients eventually, because we in the Netherlands is quite small and we follow all the patients, we saw that patients could get metastatic disease after 7 to 15 years, when we would normally think they wouldn't get any metastatic disease. So what we did is we also looked into the relation of the chromosomal pattern with the mutations themselves, because you can have structural numerical chromosomal changes, and we observed that there is a metastatic risk when you have different mutations. But we made the groups like exclusive BAP1, exclusive SF3B1, or either IFAX. So we don't have any double mutations. We did a SNP array on all the tumors. This is how this is how it looks when we get the data back. So we compared all the SNP arrays of all the patients, and eventually we had, I think, something like 214 SNP arrays available to be tested. And because we have, throughout the years, we use different platforms, we had to do some calculations to be able to compare all these SNPs, because with every new platform we get new SNPs included. So this is how the Nexus program we're using looks like. The top panel are all the BAP1 negative tumors, the middle panel are the SF3B1 tumors, and the lower panel in part A are the IFX mutated tumors. And if we look at if we look at the different chromosomes, how they look, then we see in the BAP1 negative that you always mainly see loss of a whole chromosome 3. And for the 8s, we see the long arm of chromosome 8 is lifted, so we have an amplification. We also see that in the SF3B1 mutated tumors for chromosome 8. But then you see that there are small parts that are amplified instead of the whole chromosome arm. So we made the different clusters and we looked at all the major copy number variations between the chromosomes 1p, 3, 6, and 8. And you don't have to read the bottom part, but what we saw that we looked at the size and the number of the copy number variations, and we saw that in the BAP1 mutated tumors, we had a little bit more aneuploidy compared to the SF3B1 and IFX mutated. And we also had a group with no recurrent mutations or LOH at the BAP1 locus. So if we zoom in on the chromosome 6 and 8 region, we see very clearly that the long arm of chromosome 8 is amplified, and in the SF3B1 mutations, we see only partial amplifications. And then it is interesting because approximately, I think like for 25 years, they're already doing the oncology studies in Rotterdam. And they started out doing the cytogenetics in the beginning. So we had from those cases, we had karyotypes available. So the case A is a typically BAP1 mutated tumor, where we see the long arm chromosome 8q amplified, and we see an isochromosome 8q. The lower part, case B, is also BAP1 negative tumor, which has a 6p, an ISO 6p in the tumor and a loss of chromosome 3. And panel C is a tumor with SF3B1 mutation. That looks really different because it has on chromosome 6, on chromosome 7, on 10, it has small amplified regions on the chromosomes coming from probably chromosome 8q, also on 16. So we have quite a different type of karyotype available there. So we call that more structural variants, and in the SF3B1, we saw a median of 4 structural variants per case, and those were more complex structural variants and mainly were on the chromosome 6, 8, 9, and 11. So the SF3B1 tumors have more structural variants compared to the BAP1 negative tumors. And why is that interesting? It probably means that the etiology of the tumor is quite different, and the treatment can also be quite different, because for the SF3B1, the SF3B1 gene gives rise to a spliceosome factor and has a role in the spliceosome complex, and gives rise to alternative splicing. So the treatment or the inhibition of those tumors during metastatic disease should be different compared to the BAP1 metastasis. So if we look into the prognosis, we have the IFAX SF3B1 and the BAP1, and again the slide, but for most of our patients, we do not have any genetic information available because we use eye-sparing treatment. And in Rotterdam, we use the stereotactic radiotherapy, and since the beginning of last year, we also have the proton beam facility, so also larger tumors can be treated eye-sparing. And then in the Netherlands, most of the patients do not want a prognostic biopsy, so we don't have any option for the patient, and we can't prognosticate. So because we think the number of patients will increase, because we also have the patients which normally would get an enucleation, but now there's a small group that still can be treated eye-sparingly. We want to have different ways to give the patient the prognosis, and maybe also use this technique during the follow-up. So we wanted to look a few years ago already for a non-invasive biomarker, and that is by obtaining the genetic material of the blood from the tumor in the blood of the patient. So in when the tumor dies, we get like dead cells. We have I think we have extracellular vesicles in the bloodstream. We have cell-free DNA. We have circulating tumor cells. We have metabolites. We have a lot of things that come from the tumor that are in the bloodstream. But we have to find ways to pick them up. So we started out with cell-free DNA. And cell-free DNA is actually DNA that ends up in the blood because the body cells break down and then release their cell content. So that's actually very easy. And with a sensitive technique, we expect that a low percentage of tumor DNA can be possibly picked up in the blood. And there have been successful studies being done already in breast cancer, colon cancer, lung cancer, but also in skin melanoma. And we thought, okay, we can also do that for uveal melanoma. And because we work very close with the clinical genetics department, they already had non-invasive prenatal testing running there. So we thought, okay, we give our samples to those to these people because they're already running everything for the NIPT, so they can also do it for our sample. Now that wasn't that easy, but they did it. What we had to do, because we had to change a little bit the technique, the kind of blood we're using, because normally we had heparin blood tubes, then we moved on to EDTA, and now we're moving on to Streck tube because that works very much better when we want to isolate cell-free DNA from plasma. We withdraw the blood from patients, we centrifuge it, and then we hand it into the clinical genetics department, and then they remove the plasma, including the cell-free DNA, and do then the DNA isolation. So, and then that is one part, because we give them to the clinical genetics department, and they do the NIPT, and then you get a SNP array for all the chromosomes. But in the meantime, we're also interested in analyzing the different mutations, because we want to know whether there's a gene Q, gene 11, or a BAP1, SF3B1 mutation. So what we're also doing is that we want to determine the mutations, and we use therefore the digital droplet PCR. And there's actually a DNA amplification platform, where in the lower panel we can see that it is a very sensitive method where you can pick up very small amounts of DNA. And then you get like a nice colored chart whenever there is a mutation, or even if there's no mutation present. And there have been some groups who already shown that you can identify the mutations in the bloodstream. So the data already showed that there was ctDNA in the bloodstream, and then they looked at the amount of copies, and when they have a lot of copies of ctDNA, then the patient had a worse survival. So it was also associated with the tumor load was associated with the survival. So Madic also showed that there was in metastatic uveal melanoma there were there's a higher amount of cell-free DNA compared to controls, and DC also showed that when there was metastatic disease, then there was more ctDNA present. And the interesting is that Beasley already also showed that the patient had a GNA 11 mutation, and he also has the panel working for the GNAQ mutation. So currently what we did, we saw that there was ctDNA. We could identify the chromosomal profile at time of metastatic disease. And currently we're working on the optimization of the isolation from DNA from plasma. And we're looking at irradiated patients before and after treatment, whether we can see a difference, because after treatment, we expect that you get much more DNA into your bloodstream because the tumor is irradiated and is going into regression. And we have also plasma from patients with metastatic disease, which we're, in some patients, we already shown that we have the ctDNA, but we haven't shown yet the specific mutation there. So this is actually what we're doing for the mutation profile. We are doing shallow whole genome sequencing to determine the CNV profile. because then we can say whether it's a lost monosomy 3 tumor with a gain of 8Q, or maybe it's just a tumor with a normal profile. And the amount is so little that it's quite difficult. And currently what we are having trouble with is to find a good reference cohort to put away the CMV profiles against. So the next, what we are started to do is, because the circulating tumor DNA works, but it isn't perfect. So we wanted to move on also to the circulating tumor cells. And circulating tumor cells are primary cells in the circulation, and they have a genetic profile that corresponds to the primary tumor cell. And this doesn't mean that if there are CTCs that there are also metastatic disease. So the first CTCs are described in 1869, so the idea is very old. And we know that you can detect tumor-specific mutations in CTCs, and they have shown that in other tumors. And Beasley also showed that he could identify the mutations also in the uveal melanoma CTCs. So if we can use the CTCs, that will be a possible non-invasive approach to prognosticate also in uveal melanoma. And Beasley also did it for the CTCs. He could compare it all to the cell-free DNA. So that is a very nice comparison, that you have two techniques and you can compare it in both ways. And also in the CTCs, he saw that you could detect also the monosomy of chromosome 3. But it's quite difficult, and mostly he could identify it during metastatic disease. Oh, this slide should be gone away. So this is actually a slide I want to show you for the CTCs, because we have done this the same technique, and we did it together with Aaron Beasley. He came to our lab and taught our PhD students the technique, and we changed the technique a little bit. We're using magnetic beads. And if you look at the double positive cell, that is actually then a circulating tumor cell that we could detect in the plasma. So it takes quite some time to identify a few cells. So our idea was, does the stereotactic radiotherapy influence the amount of cells we could get? Because at time of diagnosis, it is very difficult to detect the CTCs. And then we started doing the radiotherapy, because the patients get radiotherapy for 5 days. So we looked at day 0, the first day, day 3 and day 5, just to find the optimal time to detect most CTCs. And we saw that at day 5, we could detect them more. And then still not a lot. And when there was metastatic disease, we could detect more CTCs, but that's logical, because you know that during metastatic disease, there is a higher tumor burden in the body. So you expect more CTCs in the bloodstream. So these are the first data we have. Now the newly diagnosed patients, we had 8 of them. And we were able to detect CTCs, but there are only a little amount of them. And when there was a metastatic disease, that was the first patient, we could detect quite some CTCs. But yeah, the main goal is actually to do it at the time of diagnosis, because when we want to have the tumor profile, so we can adjust our follow-up protocol. So we see an average of 2 CTCs per 10 milliliters of peripheral blood, so that isn't very much. Then the last thing, because we are also, and Charles knows that we're also working in the extracellular vesicle field, because we wanted to know whether we believe that if you have extracellular vesicles, they are secreted from the tumor into the body, into the bloodstream, and it's actually a mean of communication. And for pancreatic cancer, it's already known that if there are metastatic disease, they believe that the metastatic disease, the exosomes help in the getting the metastatic disease in the liver, because they make like a niche in the liver where the pancreatic cancer cells can just home, something like they help in the communication and help in homing of the tumor cells within another organ. So if the extracellular vesicles are that important, then if they're released from the cell, then they should also have the content of the primary tumor within them. And we know that the vesicles contain genetic material, including the DNA, and the DNA can be used then for the risk assessment. So why are these then so interesting is just because the genetic material is protected. And there was a study many years ago that already showed that blood from the eye melanoma patients have an increased number of extracellular vesicles in their blood, and the tumor secretes just more extracellular vesicles there. So the cancer patients had a higher amount compared to the healthy controls. And it was a group in Sweden it was a group in Gothenburg who published this, and was an extracellular vesicle lab. And then one of the PhD students went there just to see the technique and learn about it. And they showed, in collaboration with them, we have done some protein analysis to get specific uveal melanoma proteins out on the membrane of the vesicle, just to identify these in the bloodstream. And first we tried it with, let's show. So this is an electron microscopy picture. So we see a lot of dots, and then we have to show which are the extracellular vesicles. And we have colored them, is in this picture. We have colored them with a gold bead. Do we have it? This is then the extracellular vesicle, and it has a gold bead attached to an melanoma marker, because that's also on the extracellular vesicles, so we can identify them under electron microscopy. And then the next thing is we wanted to fish the uveal melanoma vesicles from the blood and determine thereby non-invasive their mutation. So we used the magnetic beads with the melanoma, and then we had a few other proteins on the membrane. And what we did is, oh, sorry. Oh, I haven't got the picture here. And what we did is we have done this in cell lines. So from the cell lines, the 3 different cell lines, which are characteristic for the uveal melanoma with the BAP1 mutation, the SF3B1 mutation, the IFX mutation, we determined the membrane proteins. And then we could identify the different extracellular vesicles. So because this is quite a new area within the uveal melanoma fields, so we do not have any clinical application, and our results have only been achieved in cell lines. So we are also optimizing the isolation of the vesicles from plasma, because you can isolate vesicles from plasma when still we don't know whether they are uveal melanoma vesicles. So this is what we did for the tumor cell line. Is we did an assay for GNAQ, and we saw a lot of different signals, but we also saw the signals for the GNAQ there. So it's all ongoing research and nothing is finished yet. And this is the newest thing we're doing. We're looking into the metabolites, because we have a lab next door which is very interested in metabolomics, and metabolomics is quite a new field, and we know from the lung carcinoma field that they have now a device where the patient can breathe in, and then the metabolites can be found in the air and in the airway, and then they say that the patient has a risk of getting cancer or something like that. So because this field is quite new, we don't know what all the metabolites mean and what they we can't put them in any cluster, but we see quite interesting changes compared to our normal profiles. And what are metabolites? They're actually downstream, they are breakdown products from every cell in the body, and they give like a chemical phenotype in the body. So as the patient has used certain medications, so the metabolomics profile of the patient will change like the next day. And we believe for the tumor that there should be a specific pattern for the metabolites, and we want them to use them to determine a prognostic for the prognostication. We don't know whether it will work, but we just wanted to see. If we look only in the tumor, then it will definitely do that. But if we look into the bloodstream, we don't know yet. But this is really our preliminary data on the metabolomics we have. I think we have put in some 20 patients for plasma, and we've put them over a metabolomic screen, and we could identify the different groups. We selected our patients, of course, from the IFX SF3B1 and the BAP1 group, and we just put them blunts for the metabolomics profile, but with clustering, we could get some kind of profile out of them, and we see that the dark blue spots are the IFACs, the in between are the SF3B1, and then we have a cluster for the BAP1. It still does overlap a little bit, but now we're running the second group of patients, so I hope we can pull them a little bit more out and maybe identify some metabolites that can differ between the one or the other group. And this is also the study we're going to do with the proton beam patients, because they have, we only will have blood from those patients, we won't have any biopsy. So in the meantime, we weren't going to do a prospective study for the metabolomics. So is there a perfect non-invasive biomarker? So we want to use a non-invasive biomarker where we can perform a risk assessment for all melanoma patients. Currently, I don't think we have one, but there is hope we will get one in the future, so that we can use to prognosticate the patient at time of diagnosis, but we can hopefully also use during the follow-up instead of during all the ultrasounds or the MRIs or the CTs for every patient. So we have quite some people working on in the ROMS and on the Uveal melanoma project, and currently we have like 3 PhD students doing all the studies, and 2 of them are going to defend the thesis later on this year. But thank you very much. I will stop.
Emine, thank you very much. This has been fascinating. A quick tour de force through genetics of uveal melanoma. And I'm going to hold on to you for a few more minutes while Maya gives her talk, and then we'll do a discussion of both topics together.
Okay.
And now I would like to introduce Dr. Maya Eiger-Moscovich, our newest recruit, who will be joining us in about 6 months from now. I did her medical school in Tel Aviv and ophthalmology residency in the Rabin Medical Center. Then she traveled to the United States to do an ophthalmic pathology and ocular oncology fellowships at Uveal Institute, and she's now a research fellow there, and soon to come back to us to work with me and Professor Per in ocular oncology and ophthalmic pathology. One of my recent papers has been in the American Journal of Ophthalmology, has even received an editorial. So kudos Maya. And she will now tell us about new classification of pigmented lesions on the conjunctival. Go ahead.
Thank you, Shachar. One moment. Can you see and hear me?
We see and hear you just fine. Go ahead.
Okay. So, as Shachar said, I'm Eiger-Moscovich. I'm currently a fellow at the ophthalmic pathology department at the Wills Eye Hospital, and I will present a recent study of ours on validation of the WHO classification system for conjunctival melanocytic intraepithelial lesions. The study was supported by the Elizabeth C. King Trust, and we have no financial disclosures. Conjunctival melanocytic intraepithelial lesions, or CMIL, can be benign, pre-malignant, or malignant. An accurate diagnosis is significant as some lesions progress to invasive conjunctival melanoma, a locally aggressive neoplasm with potential for metastasis in 20 to 30%. The current diagnostic gold standard is the histopathologic assessment of biopsy tissue. The terminology of CMIL has been a matter of considerable debate over decades, and as a result, the primary acquired melanosis, or PAM classification, was developed by Folberg et al. In 1985. This classification scheme has formal outcome data and has been prognostically validated by various groups, and therefore is currently widely used by ophthalmologists and pathologists. It subdivides PAM into PAM without atypia, PAM with mild atypia, and PAM with moderate to severe atypia. Despite the widespread adoption of PAM, there are several challenges to it, including the diversity of the category PAM without atypia, which includes both epithelial pigmentation without melanocytic hyperplasia and melanocytic hyperplasia without atypia, the absence of melanoma in situ terminology, and an overall interpretive variability between the observers. In response to the challenges in the PAM classification, Copeland and D'Amato developed in 2009 the conjunctival melanocytic intraepithelial neoplasia, or CMIN classification. It adopted a scoring system to evaluate the growth pattern, vertical spread, and melanocytic atypia, with combined scores ranging from 0 to 10. They proposed a subdivision to conjunctival hypermelanosis, which is score 0, CMIN with atypia, scores 1 to 4, and melanoma in situ, score 5 and greater. This methodology also faces a number of challenges, including observer concordance values have not been formally documented, there is no formal outcome data, it implies that all CMIL are neoplastic, it incorporates vertical spread parameters into radial spread scoring, and it can be time-consuming. Due to the challenges in the known classification systems, in January 2018, a simplified terminology was proposed in the consensus and editorial meeting of the 4th edition of the WHO classification of tumors of the eye. Its subdivision was for hyperpigmentation only, low-grade CMIL, high-grade CMIL, and melanoma in situ. Nevertheless, this classification system is relatively new and has not been formally validated for prognostic accuracy or observer variability. We designed this study to validate the WHO classification system for CMIL by assessing the inter-observer variability, sensitivity, specificity, and accuracy, and comparing it to the two commonly used classification systems, PAM and CMIN. In a retrospective case series, we reviewed the records of all patients that underwent primary biopsy for CMIL at the Wills Eye Hospital between 1974 and 2002. Melanosis of the conjunctiva was defined clinically as one or more patches of acquired asymmetric, flat, non-cystic conjunctival and or corneal brown pigmentation. All surgeries were performed with a standard technique, and all patients had postoperative follow-up of at least 36 months. 12 international ophthalmic pathologists analyzed scanned hematoxylin and eosin stained virtual microscopic slides using PAM, CMIN, and WHO. The observers included the originators of the three classification systems: Dr. Folberg, that originated PAM, Dr. Copeland, that originated CMIN, and 6 of the panel of experts that described the WHO classification system. All slides were scored by the observers in accordance with the classification system's definitions. 64 patients that underwent 83 biopsies were included in the analysis. The clinical features of our patients cohort were similar to what had been previously reported for CMIL. The patients were older, mostly white, with most lesion in the bulbar conjunctiva. All patients underwent excisional biopsy combined with cryotherapy using a no-touch technique. After a median follow-up of 36 months, 13 patients had a recurrence and only 2 progressed to melanoma. In routine pathology practice, all 12 observers used the PAM classification system, 7 used CMIN, 4 used WHO, and 10 observers used more than one classification system, most commonly PAM and CMIN. This demonstrates the lack of standard approach to CMIN evaluation. The time needed for interpretation of a biopsy was significantly longer for the CMIN classification system when compared to PAM and WHO. The 3 classification systems had comparable inter-observer agreement of all 12 observers in distinction between the low and high-grade lesions. The agreement was moderate, reaching 76% for PAM, 67% for CMIN, and 81 and 85% for the WHO classification. Low-grade lesions provided the greatest interpretive challenge with all 3 classification systems. Those are representative challenging examples, showing in example C, the difficulty of distinction hyperpigmentation only and low-grade CMIL, and in example E, the difficulty of interpretation of a pagetoid spread of melanocytes with lack of atypia. Because only 2 lesions progressed to invasive melanoma, we chose recurrence as an indicator for aggressive behavior. An average ROC was constructed for the 3 classification systems by taking the mean sensitivity and specificity values at each threshold for each of the 12 observers. The upper and lower boundaries are the standard deviation. All 3 classification systems had comparable average accuracy, estimated by area under the ROC of 81 to 83% in their ability to identify lesions with potential for recurrence. The comparable average accuracy of 81 to 83% is demonstrated also in this table. The most optimal combined sensitivity and specificity is in distinction between low and high-grade lesions in all 3 classification systems. There are a number of limitations to our study, including the small sample size, the fact that recurrence was used as primary outcome, post-biopsy care depended on histopathologic diagnosis contributing to outcome bias. The follow-up may have underestimated late recurrences and progression to melanoma. Immunohistochemical stains were not performed, but also they were not included in the original classifications. Virtual digital histopathology slides does not identically replicate the experience with a microscope, and intra-observer reproducibility was not assessed. Nevertheless, our study also has numerous advantages. Only primary biopsy specimens from patients managed uniformly at a single oncology center with at least 36 months of follow-up were included. The observers were a group of 12 non-ophthalmic pathologists that included the originators of all 3 classification schemes. Virtual digital histopathology slides ensure that all observers reviewed the same material, and our study provided a much-needed comparative analysis of the 3 classification systems. It allowed us to get to 3 meaningful conclusions, including a finding of comparable accuracy in the 3 classification systems' ability to identify lesions with potential for recurrence, inter-observer agreement in distinction between low and high-grade lesions that was comparable, and low-grade lesions provided the greatest interpretive challenge with the 3 classification systems. As for future directions, we found that the simplified WHO classification scheme of a binary low and high-grade lesions is appropriate for evaluation of CMIL, and we plan to validate it in a future study by our group, which would include a creation of histopathologic atlas and educational courses. I want to thank my collaborators in the US, Europe, and Australia, and especially Dr. Millman, Dr. Shields, and Dr. Eagle, and thank you for listening.
Maya, thank you very much. And now I'd like to ask Emine and Maya, we see changes in ocular oncology all the time. Emine showed us the changes in molecular genetics and understanding and prognostication with different methods of checking different parameters in uveal melanoma, taking chromosomes and mutation analysis, And Maya showed us changes in histopathologic diagnosis, and they are both affecting our management of patients. So first to you, Emine. Now that you're moving to more eye-sparing procedures than previously, do you think that there is a role for final aspiration biopsy of those lesions for prognostication?
I think it's definitely a place for it, because you can adjust your follow-up protocol. Because I know already D'Amato in the UK started, Liverpool did it many years ago, that he did a study to look at to prognosticate, and then the patients in the NHS, we did get the prognostic biopsy, could have every 6 months liver MRI instead of just the ultrasound of paying for it themselves. So if we move that way and we have a high risk patients, we can do the follow-up much easier, and we will know whenever they will get the metastatic disease, and maybe be able to detect it in an earlier stage when we have only 1 or 2 liver metastasis. So we can just do a liver resection, because I know that if you have patients with minimal disease, minimal metastatic disease, then the treatment is easier. They have more options. So I think prognostic biopsy should be done. And I'm trying to convince patients. I will offer all of them a prognostic biopsy, but most of them just are so focused on treating the disease at that moment that they don't want to have a biopsy.
It's interesting because we've had the same experience, that patients are not interested in prognostication. And in contrast, patients in Liverpool, in the United Kingdom, they all wanted prognostication. So
but maybe
it's really a cultural difference.
But maybe it's also about the healthcare system, because there they will be having every 6 months an MRI paid by the NHS, and in the Netherlands everything is is for free. You pay you pay your insurance, but you don't have to pay extra when you want to have an ultrasound every 6 months. And so maybe that's the difference.
Maybe that the same goes for the United States then, because there everyone is doing prognostication, but they have to pay out-of-pocket money on most of the screening tests. And they're saying that maybe in 5 years from diagnosis, maybe patients with low risk shouldn't be followed anymore.
Yes, at the Welfare hospitals, most patients do a prognostic biopsy, and they pay for it. And I definitely feel that it does influence the way they're being followed. I mean, the centers here definitely regard patients that according to being low risk or high risk completely different. And
in what sense? How would they follow differently a patient with a low risk?
So if it's a low risk, so much earlier they will move from an MRI of the liver to just ultrasound of the liver. They will quite quickly follow them only once a year and not twice a year. And some of them, they will even stop follow after 5 years, or only follow every couple of years. And it seems that it has good results with that approach.
But still, with the knowledge we have, that we still have a group of patients with no mutations at all. So I would be I wouldn't feel good about not following them up. And even the low risk patients, even the patients with an IFAX mutation, I will still do a 6 months ultrasound until 5 years, and then once a year. Actually, I don't know about not doing a follow-up.
We do it forever. When we've just recently diagnosed the patient with liver metastasis 33 years after the initial diagnosis.
That one has an SF3B1.
Yeah, when I see them, I do tell them, well, go and do something. I agree with you that I don't feel completely comfortable with just letting them go and live their life as usual. But it definitely, it lowers the stress, and it does have a meaning on life and life quality and everything.
But for the patients, it's important because if they know they have an BAP1 mutations, I know from a few patients who had the prognostic biopsy or had an enucleation, so we always have then a prognosis there. Some of them patients, they already had their they already had a lot of things sorted out. So one of them said, okay, I know who I'm going to leave my house to, and it's going to be for my son, or things like that. They arranged their life according to that.
Now, I mean, how much blood do you draw on every visit when the patients come?
I do quite a lot, I think, but I have at the first time, when they come, I will have 2 tubes of heparin, and I will have 2 tubes of Strec and 1 tube of EDTA. And during follow-up, I will do 2 EDTA, 2 heparin. And when I know they have metastasis, because I will do the liver ultrasound, and they will get them in the morning, and I will see them in the afternoon in the clinic. In the meantime, I have the report. I will do, if I know they have a metastasis, I will do an additionally Strec tube. So 4 to 5. But I will do that every 6 months. And when they have metastatic disease, I will do it in between. Extra.
And do you feel that any of those circulating tumor DNAs or exosomes screening can become readily available one day and may influence your treatment?
For the NIPT, they didn't believe they could do that. So, and it's now currently, it's still in research, but a lot of countries are having it as a standard at 11 weeks of pregnancy, 10 of 11 weeks of pregnancy, they do it like standard, even if it's still in research mode. So I believe if we can find ways to improve the detection, so you only need a very small amount of DNA, and only the thing which is now the problem is that we don't have good enough amplification procedures, because we have to amplify a very small region of DNA. So if we can do that, then we will have like a normal prognostic test. And I believe that the exosomes is a very good one, because we know what the membrane markers are for that. And I believe that the CTCs will also work in that way, because for the CTCs, you only have to have like 2 or 3 cells, so you can determine the genetic makeup. And for the cfDNA, we go in the way as we do for the NIPT analysis, that we want to have a profile. So we would want to use them complementary. So do the cfDNA, the circulating tumor DNA, together with the CTCs.
Interesting. Now, Maya, I want to ask you about the change in classification. So we've seen that there's very good concordance between these 3 methods. Mm-hmm. And as a student of Paul Folberg, I was very happy to see that the PAM classification was quite fast and quite, they had the highest area under the curve in one of your last slides. And so, do we really need to change? Does it affect our treatment?
We don't have to, but I think that since there are quite a few people that are not completely pleased with that, and some use PAM, some use CMIN, some use WHO, it would be good to have one standardized approach that all of us will use. Also, one of the other problems is that the WHO is more similar to approaches that are common by dermatopathologists or general pathologists. And the PAM is a bit different. It's a different language. So there would be easier for just the general communication between different areas to use the WHO in all, as a standard. But I don't think that since we saw that it is that similar, it would be horrible to just continue as you're used to.
So I get a sense that there's a difference between people who are trained surgical pathologists and people who are trained ophthalmologists with a fellowship in ophthalmic pathology in their approach to the issue.
Yeah.
And to name one big name, that would be Sarah Copeland, who is an excellent pathologist, but she's coming into the field from surgical pathology. And I know that both your mentors in pathology, the same as mine, are also trained in surgical pathology, but they're mostly ophthalmologists in their view of things. So what do they think about it?
So I think it definitely disturbs more. I mean, the people that are mainly surgical pathologists are less pleased with the PAM, and it disturbs them more about the lack of communication and different language. But I do think that also my mentors and a lot of the people in the field feel that it shouldn't be standardized and that the WHO is a good approach. Just see that in this article, I mean, we had 12 people, 12 of the most known pathologists worldwide from Europe and the US, and most of them agreed that this is the best way to go. I mean, some of them used mainly PAM and some mainly CMIN, but all of them, I think most of them felt that having the WHO as a standard should be a good middle way.
Okay. Emine, do you think that your pathologist would adopt this new classification?
I know Rob is very keen on having very clear definitions. So, and he works very much with the pathology from the UK. So we also follow their guidelines. So I think he will adopt it. But what is the role for the molecular pathology in here? Because also the conjunctival melanoma have a molecular profile. So why isn't that one also incorporated into this new classification then?
I think we need someone to take that up.
We will do that. Now, I know Rob Verdijk is very interested also in the molecular profile of the conjunctival melanoma. I also know the group of in Denmark is doing that, and Sarah Copeland is also very keen on doing that. So I think if you look at the uveal melanoma, we had the AGCC classification, which is actually a clinical classification, and then you have the extraocular extension in there. But the genetics is much more convincing in the prognostication of the patients, and even the small lesions can have a monosomy 3. So and I think that will be the same for the conjunctival melanoma.
I agree. I think that this is a way to standardize the clinical definition, but definitely there is a lot of research regarding the genetic part, and as time will pass by, we will definitely go more and more towards the genetics as in uveal melanoma. I think it's just a bit lagging behind, but we'll get there.
So I think we have a question from the audience, and I think it's for Emine. And do you think that a single biopsy from a tumor will be able to determine the proper prognostication? Is there no intertumor variability in the mutation presentation?
There is, we always said that there is like a minimal tumor heterogeneity, but the largest clone will determine the tumor prognosis. And I know that Jens Kilgaard did a study where he looked at the different compartments of the tumor in different places, and he saw a little bit heterogeneity. But if you have the many mutations, you will see them throughout the tissue. And most of the cases, people will take like 1 or 2 biopsies when they take a biopsy. Because when I do a biopsy, I will do it with a vitrectome, because I know how to do that. And it's different when you use a fine needle aspiration biopsy, but you will always have enough cells. And even if the compound of the part of the tumor is very, with the mutation is very little, then you can still identify the mutations. So there is intertumor heterogeneity, but I think you will still see it, because I have also did biopsy only once because they were small lesions. And then you still get the genetic profile.
And one last question regarding those biopsies is, you've shown that post-irradiated tumors exert more cell-free DNA into the bloodstream. Yeah. And I know that cell-free DNA disappears very rapidly.
Yeah.
So how soon after your treatment would you draw blood to look for those cell-free DNA particles?
What we're now doing is doing it at the time of diagnosis. We do it at the first day of radiation treatment, the third day and the fifth day. So we do it during the treatment. And because the stereotactic radiotherapy is given like 5 days, we can just plan it when we withdraw the blood. But for the plaque radiotherapy, I don't know how it is because you have a variable time that the plaque is on. So we would definitely do it at the last day of treatment and somewhere in between. Because if you look afterwards, we started out doing it after 2 or 3 weeks because then the patients came for follow-up and then we couldn't really detect it. So 3 weeks is too long. So that's why we moved on because the patient was already in the hospital coming in for the treatment and then they first get the radiation treatment and then go for blood withdrawal.
Thank you both very much. It's been a really fascinating evening. And I'd like to thank our audience for attending for this hour. And see you next time.
Thank you.
Thank you for the invitation.